Hello, everybody. We'll just give everyone a chance to come on in. Good morning, good afternoon, good evening, depending on where you are in the world. Thank you for joining us. We are going to be discussing today later stage treatment options. So hopefully you're in the right place if that's what you signed up for. Before we get started, I wanted to give a brief but very heartfelt thanks to our corporate partners and our individual donors. Thank you so much for your support. We certainly could not do these programs without you, so we are very appreciative. Tonight, we have the wonderful Dr. Lauren Pinter-Brown. Lauren, thank you so much for being here with us tonight. Dr. Lauren Pinter-Brown is a nationally recognized hematologic oncologist. She joined the UCI Health and the Chao Family Comprehensive Cancer Center to lead the growing team of physicians who diagnose and treat patients with lymphomas. She has a long-standing clinical interest in malignant lymphomas with a focus on T-cell and skin lymphomas, and Dr. Lauren Pinter-Brown is also a member of our board. So I am going to go ahead and stop sharing and turn things over to you, Dr. Pinter-Brown. Thank you so much for being here with us tonight.
Okay. All right. Can you see my screen?
Yeah. Not yet.
Uh-oh. Uh-oh, then we're in trouble.
That's all right. We'll get it worked out.
You really don't, huh?
Click that little icon on the bottom. Let's see.
Try it again.
Okay. Okay, yep, we can see it, and just click the thing. Yep, and just so everybody, we can see it now. And just a brief housekeeping note, while we are talking tonight, if you have any questions, we're gonna reserve time at the end. There's a little icon at the bottom of your screen. It says Q&A, and you can just go ahead and submit it there. So I'm gonna turn things over. Thank you.
Okay. And we can even advance. Okay, so I'm mainly going to be talking about mycosis fungoides and Sezary's, but there's a lot of different cutaneous T-cell lymphomas. And mycosis fungoides, just as a kind of an introduction, it's a weird name. It comes to us from the 1800s from a French dermatologist. He thought the lesions looked like fungus. It is the most common cutaneous or skin lymphoma. And pathologically, the most important thing about it, what sets it aside from everything else, is that it involves the very most superficial layers of the skin, which is called the epidermis. So this is an example of what a pathologist might look at. And where the arrow is showing something called a Poteligeo microabscess, which is something that you see in mycosis fungoides. And you can see that where that is located is very close to the surface of the skin, which is at the top part of the picture. Sezary syndrome is a subset of mycosis fungoides, again, from a French dermatologist almost 50, 60 years later, named Sezary. And it is characterized by cells in the blood that are demonstrable and patients that are all red and have scaling of the skin. They might have enlarged lymph nodes. They might have changes in their palms or soles or their nails. They may have swollen legs or changes in their eyelids, and it itches. So when we're talking about later stages, I thought I'd define what later stages is. So we have different stages for mycosis fungoides and Sezary's than in other lymphomas. And it's called a TNM staging system, meaning it has to do with T is tumor. In this case, it's how the skin looks. N is node. In this case, how the node looks under a microscope when it's biopsied. And M being some other area that's not skin or nodes. So we have stages to suggest appropriate treatments so that we know that when people have more advanced stages, we're going to pick different kinds of treatments, not so much the skin-directed treatments, things that we would do to the skin just by themselves, but more treatments that would go systemically so that we would be treating everything at once. Stages in general tell you a little bit about what to expect from the condition. It definitely tells us where to look to see if our treatments are effective. And when we do clinical trials, it's really important to have people of like stages involved in the trial so that we can compare one person to the other. But it definitely doesn't tell us how an individual is going to do. This is a statistical thing. And mycosis fungoides doesn't naturally go from one stage to the next. So somebody that, say, has stage 1 may never go beyond stage 1. So these are what the cells do, a picture of what the cells do that are involved in mycosis fungoides, and they're migratory. So they move. So they go between the lymph nodes, that's the blob in the center. They go in the lymphatic channels, they go in the blood, they go through the skin. They spend a lot of time in the skin because they like being there. They have something almost like Velcro on their surface that allows them to stick there. But they do, in fact, move, so that when we are looking at staging for mycosis fungoides, we look at all the areas where these lymphocytes that cause mycosis fungoides, the white blood cells, go. So we look at skin, nodes, organs, and blood. So this is an example of the staging. And when you put it all together, where the blue bracket is what I would consider an advanced stage. So 2B is somebody that has a tumor. Tumors are raised areas on the skin. They're usually pretty large, at least the size of a quarter maybe. And stage 3 is somebody that's all red. Stage 4 goes into people that have lymph nodes or other organs that are involved, or a very significant amount of blood involvement. So there's a lot of different treatments, just to give you an example. And obviously, I'm not going to go through all of these. But on the left of this group are skin-directed therapies, and those are the ones that are used for people with less advanced disease. And so I'm going to focus on the middle column and the column to the right. So when you start to consider how to plan treatments, usually you plan treatments in sequence. We don't do a lot of kind of combination treatments, although there are patients that end up on combinations of things. And we usually choose the therapy based on the stage, but there's other considerations too. So since there's so many different kinds of therapies, we can look at what's available to a given person, what the short or long-term side effects are, what's convenient for the person, what they have access to. And then we know from using these treatments that certain treatments work better in certain situations, and certain treatments work faster or slower. So we can kind of tailor make the selection to the particular person and what their issues are, and that particular time for them in their journey. In general, we haven't studied a lot of combinations, and we try and preserve people's immune systems as much as possible. So, what do we do when we're choosing treatments? We look at the root. So if you, as a person, said, I really only want something to take orally, then that limits our choices. Particularly with COVID, a lot of practitioners have been looking at oral treatments because we're trying to keep people out of the clinic. Now, maybe not so much again. Again, rapidity of response, chemotherapy always works the fastest. Then things that are called HDAC inhibitors, which I'll go through. And finally, biologics, things that work with the immune system. The stage is very important, kind of going in reverse. Biologics, not so helpful with nodal diseases. Retinoids, things that are like vitamin A, may be particularly good in tumors. Some drugs like mogamulizumab works really well in blood. So we kind of, again, look at what the target is and what we're trying to accomplish. And then certainly everybody may have other medical conditions. So you have to look at what else the person is dealing with so that you don't make something else worse. And then finally, availability, things like photopheresis. If you're living in an area where there's no photopheresis, it's not a choice. Unfortunately, if you have certain kinds of insurance, Medicare being the biggest problem, some of these drugs are extremely expensive and it's just prohibitive. It's not a good choice. So these are the things I am going to talk about very briefly. So I'm going to talk a little bit about photopheresis. I'm going to talk about Bexarotene, which is an example of a retinoid or something that looks like vitamin A. I'll talk about HDAC inhibitors. We have 2 of them on the market. One of them is intravenous, which is romidepsin, and one of them is a pill, which is vorinostat. I'll talk about mogamulizumab, which is a new antibody. I'll talk about brentuximab vedotin, which is an antibody, which is conjugated or connected to a chemotherapeutic agent. And finally, I'll talk about a very old chemotherapeutic drug, which is methotrexate, and a newer chemotherapeutic drug, which is related, called pralotrexate. So all is systemic therapies, and what I'm not going to talk about is the bottom half. So conventional chemotherapies, combination chemotherapies like CHOP, we don't use that so much. So I'm not going to talk about them a lot, but if somebody has questions, certainly you can answer. So let's focus on photopheresis for a second. So photopheresis, you may have heard of something called PUVA, where a person takes this drug called Sorolin, the P is silent, and then they go into a light box with UVA. So photopheresis does that same procedure for somebody's white blood cells. And Sorolin's such an interesting compound because people have known about it since Egyptian times, that if you eat certain weeds along the Nile and you lie out in the sun and you have a skin condition, it will make it better. Primarily, probably not for mycosis fungoides, but for psoriasis, but turns out it works for both. So it's a machine, it's a pheresis machine. A needle is placed in someone's arm. Their blood goes through the machine. I'll show you the machine in a second. The machine has what's called a centrifuge in the center. It spins the blood around really fast, and it separates out white blood cells, which are put into a bag. And the white blood cells are collected, and then they are the ones that get the Sorolin and the light. And so that changes them on their surface. It also makes it so they can't make any more of themselves. They become infertile. And then it's all given back to the person. And it's kind of like a vaccine. We've been talking about vaccines a lot, but it's kind of like a vaccine. So this is what the machines look like. And basically that's what happens, is that the methoxysorolin changes the surface of the cell. The cell can't divide anymore. The cell becomes immunogenic when it's given back to the person. And then hopefully the person's immune system notices that it's there, which it didn't notice that it was there before, perks up and pays attention, and then kills off the cell. So photopheresis has very few side effects, but it works real slow, like over months, like 6 months. Something that works slightly faster, but not a whole lot faster, is something called Bexarotene. Bexarotene is a pill. It's what's called a retinoid. We have lots of retinoids, and they have different specific receptors. So, all right, maybe some of us that are a little vain have used what's called pan-retinoids on our face to reduce wrinkles. Those are retinoids. People use retinoids that are specific for a certain receptor to treat a kind of acute leukemia. And Bexarotene is specific for a different receptor called RXR, and it works for mycosis fungoides. So it works very slowly, but not quite as slowly as photopheresis. It takes about 4 months to see an effect. It's a pill. Its side effects are mainly things that you would see in the blood. And a lot of people that take Bexarotene end up on other pills for high fats in the blood or low thyroid. That's what we see in the blood. It goes away very quickly when the pill is stopped, but we have to manage it when somebody's on the pill. Then we have HDAC inhibitors. And I guess the theme here, if you can appreciate it, is all the very different ways all these medicines work. So we have a lot of selection of treatments, and they're not one the same as the other. So HDAC inhibitors are really interesting. This is a diagram of somebody's DNA. So DNA is the thing inside the cell that tells the cell how to grow and how to divide. And there's a lot of it. So to keep it organized in the cell's nucleus, it gets spooled around these things called histones. In this picture, they're the little like turquoise rectangles. So just as you're wrapping thread around a spool, and if they're wrapped very close, then the material in between, it can't be read when the DNA is read and the cell is divided. But if they're spread further apart, just like a scroll is open, then the DNA can be read. So what histone deacetylase inhibitors do is they put more spacers in, if you will, or allow for more spacers in between these histones, so that the genes that were previously not seen are now being able to be read. And they happen to work in T-cell lymphomas, not in a lot of other cancers, but in T-cell lymphomas, they're very useful. So we have a bunch of them. The ones for cutaneous T-cell lymphoma that are FDA approved are vorinostat, which is a pill, and you take it every day, and romidepsin, which is an intravenous drug. You get it once a week, usually for 3 weeks in a row with a week off. the side effects, unlike Bexarotene, where the side effects are something not that the person can see, but the doctor sees, these drugs have side effects that the person sees. And most of that is fatigue and kind of a funny taste of the food, maybe a low-grade nausea, not a lot of blood changes actually, but the person can often notice that they're getting the drug. Then we have this drug, brentuximab vedotin. So there's a marker on some cells in mycosis fungoides called CD, or cluster designation 30. So what this company did was they developed an antibody that targets CD30. So the antibody goes into the blood. Antibodies in general are things that we make to fight infections, but there are antibodies that are created in a laboratory that pathologists use for diagnosis and that clinicians use to treat people. So this is an antibody that will see CD30 on a cell and attach. So what they did was they attached a chemotherapeutic agent. It's called MMAE. You've probably never heard of it other than this drug. It's kind of a weak chemotherapeutic agent. And when the antibody attaches to the cell, then this chemotherapeutic agent gets kind of engulfed by the cell, and then it kills the cell off. So it's kind of like a Trojan horse, a way to get the chemotherapy specifically to this cell. So this drug was on the market for quite a long time for other lymphomas, for Hodgkin's lymphoma. And finally, a trial called the Alcanza trial was done in people that had cutaneous T-cell lymphoma whose cells had some CD30 on them. It was a phase 3 trial, so it compared this drug to methotrexate or Bexarotene. And this drug did really well. So the FDA gave it an indication for CD30 expressing mycosis fungoides, which allows the drug to be paid for by insurance. So this is an intravenous drug, and it's given every 3 weeks. Its main side effect is a neuropathy. So meaning numbness or tingling of the fingers or toes, and that's because of the kind of chemotherapy that they attach to the antibody. This is just a picture showing the same thing. And finally, our most recent FDA-approved drug is mogamulizumab. It's an antibody. It doesn't have chemo on it. It has its own target, which is called CCR4. And it was studied in mycosis fungoides and Sezary syndrome in a trial called the Maverick trial. These trials have names because it helps oncologists remember what the trial is. They're acronyms. And it was a phase 3 trial. It was mogamulizumab versus vorinostat, the HDAC inhibitor. And this drug kind of came out ahead of vorinostat, and so the FDA approved it for the use of mycosis fungoides and Sezary syndrome. What's unique about this drug, which is intravenous, is it is extraordinarily good at clearing out cells from the blood. So it works really, really well for Sezary syndrome. And a picture of some of these drugs. And lastly, these drugs actually aren't FDA approved for the treatment of cutaneous T-cell lymphoma. Methotrexate is a really, really old drug, maybe from the 70s. And pralotrexate is a newer drug, maybe at least from the 2000s, but it's FDA approved for node-based T-cell lymphomas. However, it was studied in skin lymphomas, so we know, how to utilize it. So methotrexate was utilized a long, long time ago, and it's used mostly as a pill form, although you can give it intravenously. Wasn't studied with the same rigor that pralotrexate was, but it is actually useful. And pralotrexate, which is intravenous, was studied by a group of investigators for cutaneous T-cell lymphoma. And what they tried to do was they tried to start off with a lower dose than we use for the node-based T-cell lymphomas and kind of see if it would work. And they got down to about half the dose that we would use for a nodal T-cell lymphoma with responses, and a kind of slightly different schedule. So this drug for cutaneous T-cell lymphoma is given 3 weeks out of 4. It's an intravenous drug, but it's really fast, like 15 minutes. Doesn't cause a lot of nausea, it doesn't cause hair loss. It causes some mouth sores, and we often give vitamins, believe it or not, and other medications to prevent that from happening. So lastly, I'm just going to mention this briefly because people sometimes ask about it. So you might have seen there's a lot of press about PD-1 inhibitors. People think about it like immune therapy. People always, when patients ask me, they ask me about immune therapy. So what these drugs do, pembrolizumab, is they release the brakes on the person's immune system by inhibiting something called PD-1. And they've been really useful for a lot of very hard to treat cancers like melanoma. So somebody decided to try and look at them in cutaneous T-cell lymphoma. And there was activity, but interestingly, when people had Sezary syndrome, their skin actually got worse and then got better. So it's something that you might ask about, but I would use a little bit of caution because in other T-cell lymphomas, when this drug and like drugs were studied, it actually accelerated the lymphoma. So it's an interesting thing if you've ever wondered if these drugs have ever been studied in mycosis fungoides, but I think we need to probably learn a little bit more about them before we consider them the standard of care. And then just a picture, and that's my talk. I wanted to allow a lot of time for questions because I know that that's usually of a lot of interest to people that are listening to these talks.
Thank you so much, Dr. Pinter-Brown. That was wonderful. We really appreciate the overview, and thanks for allowing time for questions. It's always the most popular part of the program, so we really appreciate it. Let's see, I'm going to stop sharing your screen if that's okay.
Sure.
So that we can see your beautiful face more clearly. There we go. All right. So our first question, has oral Bexarotene been studied for systemic use? I have stage 4 PCALCL and I'm taking Bexarotene. It is successfully keeping the disease stable in my case.
I'm not sure what you mean by systemic use. It's a systemic drug because when you take it, your body absorbs it. Do we give it intravenous? No. There's been other retinoids that people are studying intravenously, but they haven't been marketed. And has it been studied for primary cutaneous ALCL? Not so much, but there are some papers about lymphomatoid papulosis, which is a related condition. And it has been useful for people with lymphomatoid papulosis. Sometimes the difference between primary cutaneous anaplastic large cell and lymphomatoid papulosis isn't even so clear.
Okay, let's see. When would you recommend a later stage CTCL patient start considering a CAR-T clinical trial or SCT?
Well, okay, let's start with SCT. So let's call SCT, for people that don't know what that means. I assume the person is talking about an allogeneic bone marrow transplant or stem cell transplant.
So, yeah.
That means the donor is somebody else, and they're giving you their cells so that you have received a new immune system that would be better at controlling your lymphoma than yours is. We generally use allogeneic transplantation when we can foresee that we don't have a lot of other options for a patient, or if a patient has advanced disease and they're particularly young, so that we think that, yes, we might have options for 10 years, but that's still not going to get them very far in life. Weirdly enough, or, well, I don't know if it's weird, but allogeneic transplantation works particularly well for people with Sezaries, not so well when somebody has tumors or nodal disease. CAR-T cells, okay, so for people that don't know what CAR-T cells are, a machine, just like that pheresis machine, takes T lymphocytes from the patient. It's sent to a company or a laboratory. They re-engineer the cells so that they will go after a target. And then they're given back to the person after the person receives chemotherapy so that they can accept the cells, and they go after the target. So the marketed CAR-T cells, even though it has the letter T in it, they're for B-cell lymphomas. The target is CD20, or CD19, excuse me, which is on B cells. And the problem with CAR-Ts for T-cell lymphomas is if you eradicate the person's all their T-cell lymphomas, T-cell lymphocytes, excuse me, you make them into somebody like an AIDS patient that has no immunity. So it's been a real problem. However, I have to say, I was just approached last week with a new idea for a CAR-T for T-cell lymphomas. So what is in existence right now? There's a couple of trials around the country where the target is CD30. So hoping that the CAR-T won't hit every single T lymphocyte in the body, but just the ones with CD30, which is not so many. And then there'll be this new clinical trial. So CAR-Ts for T-cell lymphoma are really in its infancy, even more so than for B-cell lymphomas, where we are still working out what the utility of it is and how to deal with the side effects that they may cause.
Okay. Can you explain more accelerated problems with Pembro?
Okay, so what's been noticed is that some T-cell lymphomas, what it's called hyperprogression. It's like you've removed the brake on the lymphoma and the lymphoma kind of goes wild. It was first described with adult T-cell leukemia lymphoma, which is a T-cell lymphoma that's associated with a virus called HTLV1. But more recently, it's been associated with other T-cell lymphomas as well. So, we don't understand T-cell lymphomas as well as we should, what keeps them in check. And it appears that for some people's T-cell lymphomas, this PD-1 axis is what's keeping it in check. So that when you inhibit it, you impair it, you've removed the brake from the lymphoma and the lymphoma starts to really grow rapidly and fast. So we need to learn a lot more about what keeps T-cell lymphomas in check, or how we could learn about an individual lymphoma to know whether PD-1 inhibition would be a bad idea for that particular person.
Okay. How frequently do people die of MF or Sezary?
Well, less and less. So if any of you have gone online to look at survival curves, you have to know that they're really, really old. They're the same curves that I've looked at since the 80s. And all of us that have been involved in this area for a long time know that our patients live a lot longer than they used to, a lot longer. So I can't give an answer of how often people die. Unfortunately, some people still do pass away from Sezary syndrome or from mycosis fungoides. But I do know very strongly that our patients live a lot longer and a lot better lives than they did 20 years ago when those curves came about, and less people die. And the more and more treatments that we have as options, hopefully the longer and longer people will live productive lives.
Okay. What would you recommend for later stage patients that had good blood results on moga but skin worsened?
Well, that's interesting. So I didn't talk about what mogamulizumab's side effect is, which ironically is rash. So the first question I would have is the skin worsening because of the mycosis fungoides or because of the rash from mogamulizumab, which strangely looks a lot like mycosis fungoides? So that would be one question. Another kind of thing that I've noticed is that sometimes people with Sezary syndrome, their blood gets better, the total body redness gets better, and then they develop patches that looks like mycosis fungoides. And then for those patients, sometimes then, and it does look like mycosis fungoides, but it must be a different clone, I treat them just like patch stage mycosis fungoides. I might put them in a lightbox, something that's skin directed. So I guess the answer is exactly why is the skin worse? And, how does the skin look worse?
Okay. And you'll have to excuse me going on mute. My dog keeps barking, everyone.
Mine too. Mine too. So I'm sorry. They were going wild. I have to say the other thing just to mention is sometimes the rash from mogamulizumab looks like Sezary's too. You can get all red. So again, it's just really important to understand as best as possible why the skin looks worse.
Okay, thank you. This is a big one. How much more research is on the pipe? It's coming down the pipeline.
Well, it's endless. I mean, sometimes it ebbs and flows. At the present time, there's not a whole lot of, to me, real fascinating trials going on other than this CAR-T. I'm really interested in it. But it definitely ebbs and flows. So there's been, a year or two that goes by where there's not a lot of new drugs, and then all of a sudden we have a lot of new trials. And it's a very big interest in the lymphoma world because we have a pretty good handle on B-cell lymphoma and Hodgkin's lymphoma, and T-cell lymphoma, because it's not as common, has kind of gotten short shrift. So I think that it's a really a big unmet need. And so pharmaceutical companies who are a lot the instigators of trials are very interested in knowing if their treatments will treat T-cell lymphomas. So it's endless, though. You can see from all the different ways these drugs work. People are always coming up with some novel mechanism that you could treat somebody with.
Mm-hmm. It's encouraging.
Mm-hmm.
I have stage 4. I've done vorinostat and moga, now on doxil. What do you think of that?
Well, it's too bad we can't talk to the person. I
Yeah.
don't know what stage 4 means. So I'm a big believer when I'm approaching a patient and trying to figure out what to treat them with. And lately, when I've been lecturing to doctors, I've been very focused on what part of the body are we trying to treat? What are we trying to treat exactly? So am I trying to treat the blood? Am I trying to treat tumors? Am I trying to treat lymph nodes? Because there's different drugs that work differently in different areas. So let's say there's 2 ways I could think about a person commonly being stage 4. One would be there's lymph node or lung involvement or something like that. And the other would be a lot of blood involvement. So if somebody had a lot of blood involvement, I'd probably give a mogamulizumab. If somebody had tumors or nodal involvement, I might be thinking more about things like doxil or romidepsin. But there's specific drugs that actually are better at certain targets than others. So we'd have to know a little bit more about what the stage 4 means.
Okay. And whoever has typed that question, if you would like to send in more information, we can revisit it. Let's see. Are these treatment options recommended based on the severity of the MF symptoms, i.e., if the symptoms aren't severe, is it necessary to be treated to prolong life expectancy, or is the life expectancy not part of the testing? Can we live without these treatments?
That's such a good question.
Mm-hmm.
So nobody really has ever been able to look at life expectancy. And the reason for that is you can imagine that during somebody's life, they're going to get a lot of different treatments. So if you're going to study, it's going to be very hard to figure out if any one treatment prolongs somebody's life. So we've never been able to demonstrate that any one particular treatment prolongs people's life. You would think, though, since back in the day, when I started doing this, what people would die from is actually infections, mostly, not the disease per se. Mm-hmm. So if you're able to keep somebody's skin intact and keep their immune system functioning, you should be able to decrease their death. So a lot of the ways that these treatments work is by improving somebody's skin is a very important part. Obviously, if somebody has something like lung involvement, we need to treat that because the person's lungs won't work so well after a while. So I think that, to answer the question, doesn't a patient with advanced disease need treatment to live? I'd say, yeah. In early stage, I don't know, because nobody goes to a center like mine and then refuses to be treated.
Right.
They're not going to bother with me either. So I don't see people that aren't treated other than people that weren't treated for a long time because they didn't know what they had.
Okay. Is lightbox useful for late stage?
Well, some dermatologists use it to decrease itching. when, if somebody had like one tumor and the rest patches and plaques, and you could get rid of the tumor maybe by radiating it, it might have a role there too. Does it help reduce node involvement or lung involvement or blood involvement? No. So most of the time when somebody has advanced disease, light therapy isn't a part of their treatment. Though there's some, as I said, there's some instances where it would be. And particularly when people are all red, like they have Sezary syndrome, sometimes light is really hard to deliver because it makes them even more red and irritated. So sometimes really would be a challenge to give light to that sort of person.
Mhm. Okay. The person has clarified the stage 4 question. My stage 4 is blood, skin tumors, skin rash. Tumors have just about disappeared and everything is currently better or stable. And the original question was, I've done vorinostat and moga, I'm now on doxil, and was wondering what you thought about that.
So, all right, so each one of those treatments would treat different parts of your disease. So the moga is good for the blood, not so good for the tumor. The doxil is good for the tumor, but not the blood. The vorinostat would maybe approach the blood a little bit and the tumor a little bit, but actually romidepsin might be a better choice of HDAC inhibitor in that situation.
Okay. Thank you. Would you recommend participating in the CD30 and CAR-T clinical trials?
Well, absolutely. If you've exhausted other options, I wouldn't go right to it because these are very early stage trials, and we don't know, how they're going to work, what the side effects are. But certainly, if your doctor is telling you that I don't know what else to utilize, we've gone through a lot of the very good treatments, and your condition is either CD30 positive, or when this new trial comes out, you would be eligible for that. I think, yes, that would be an excellent thing to participate in.
Okay. This one has a little bit of a backstory. My MF advanced from 1A to 2B over a 10-year period while living overseas. I was only getting phototherapy and eventually also skin-directed radiation. After 10 years, I returned to the US. I have been given methotrexate for a few months and more radiation. About 4.5 years ago, I started Valchlor and continued with phototherapy. My disease has stabilized and I have no more tumors and I am much improved. I guess I am 1A, 1B now. Is that kind of improvement normal?
Yes. So, all right, first of all, you don't get restaged. Staging is a concept that you only do when you meet the person. So you don't keep changing the stage around. So the way you would describe yourself is I used to be I was stage 2B when I presented. I had tumors, but now they're gone, just like you said. Yeah, I think the methotrexate's probably what got rid of the tumors. So that's great. So no tumors, then you can approach what's left if it's patches or plaques like you would approach earlier stage disease. But people have to be mindful that you had tumors at one point because it could happen again. So usually when someone has a history of tumors, I might continue them on some therapy that would suppress tumor formation and then treat whatever remains, if it's earlier stage disease with things that are directed to the skin.
Okay. I have MF stage 1A, no treatment at the moment. I've had UVB, it worked. I've been in remission for about a year. Is there something that can be done to keep my MF at 1A?
No, but statistically, your disease won't ever move from 1A. So statistically, only about 2% of cases does the disease go from 1A to some higher stage. It tends to be older people that didn't respond to their initial therapy. So the vast majority of people that have 1A disease will always have stage 1 disease. Some people might advocate maintenance light therapy to keep the rash away, I don't know if it will prevent it from going to a higher stage, but sometimes I'm not a big advocate of maintenance, but there are many people that are, that instead of stopping the light therapy, the person gets light therapy on some interval, like be it once a month or something like that. And the main concept there is not to prevent it from getting to be a higher stage, but for preventing their skin rash from coming back.
Okay. Are you aware of PCLX-001 undergoing clinical trials starting in May? And then they have parentheses, I'm so sorry, PACYLEX Pharmaceuticals. And then they said, do you have an opinion on NMT inhibitors? Sorry if I slaughtered some of that.
Well, sometimes I know what something is, but not by its research
Okay.
label.
Yeah.
So
We'd
have to take the time out to go look that up.
Okay.
So when drugs are being developed, just so other people know, there's an abbreviation at the beginning that has to do with the drug company. That's why this one starts with a P.
Okay.
And then it's assigned a number, what number compound it is for that drug company.
Okay.
And unless I have the trial, and even sometimes if I do have the trial, because I can't remember numbers,
Yeah.
I know it by some other name. Eventually, if it's a compound that's useful, it gets a generic name. And if it's going to be marketed, then it's assigned a marketed name. But in the beginning, they all have, everything that's studied has like 3 letters and a number.
Okay.
So I'm sorry not to, you have to look that one up.
Okay.
If you tell me, I can look it up as we're talking.
You're so
but we'd have to look that one up to see if I know it by some other name.
okay. Let's see. Spot radiation or full body radiation. How long is this helpful and what are the downsides?
Okay. Well, spot radiation is only a local phenomenon, so it's like a flashlight. So the only area that's treated is where you flash the radiation. It will be probably pretty good at eradicating whatever is in that one little area, but it won't control anything else. Total body skin irradiation is developed for the total skin, and it's a lot more involved. So the downside is sometimes people will lose their hair or their nails, or those will change in texture. Sometimes people will have their sweating impaired. And it's a very involved kind of radiation. It goes on for, well, depending on how much and what schedule you use, it may go on for weeks. And in general, when you do total body radiation, because people with more advanced disease tend to recur relatively quickly, you use it as a tool to kind of rapidly improve the skin, but then you have to have a backup plan. So as soon as the radiation is done, you have your backup plan that you put into place to try and keep the skin nice like that. So in and of itself, for a patient with advanced disease, it won't last for very, very long.
Okay, thank you. Let's see. Regarding mild post-brentuximab vedotin swelling in hands and feet, are massage, exercise, and compression clothing the recommended treatments, and are there others? And then they noted the BV infusions were for systemic ALCL that had reached some lymph nodes.
I have to say that swelling is not a usual side effect of BV vedotin. I'm wondering if you have swelling because it's lymphedema, because of the lymph node involvement. I don't know. But I can't really recall anyone having swelling from BV vedotin, or what the mechanism might be. So it's hard for me to give an answer. If it's from lymphedema, then usually we do compression and lymphatic massage, and then there would be certain activities that you would be cautioned not to do, like repetitive actions with the limb that's swollen and wearing tight clothing and that kind of stuff.
Okay. And unfortunately, that one was submitted ahead of time, so we can't clarify. Let's see. Are immune suppressed patients receiving protection from any or all of the vaccines available?
We were just talking about
Question of the day.
So, all right, here's the story. I don't know the answer. People with lymphoma typically don't get the same responses to vaccines as everybody else. But every person would be different depending on what their lymphoma is, how advanced, what their other treatments have been. So we were just talking about, and I hate to unleash this, but maybe I should, that the Leukemia Lymphoma Society is apparently carrying on an investigation of how well people with lymphoma are responding to vaccines. So if you want to participate, I would say go onto their website, which I have not done yet because I just found out about this morning, and check it out. And then you might know for yourself individually, perhaps, some parts of the response. But having said that, these vaccines are kind of interesting because they engender an antibody response and a T cell response. So what I maybe should have said at the beginning of this talk is we have two kinds of lymphocytes, right? B like and boy and T like and Tom. We're talking about a lymphoma of T like and Tom lymphocytes. B like and boy lymphocytes, they make antibodies, and normal T cells also are part of our immune system and they act in a different way. So the testing that's being done is looking at antibody response to the vaccine. So it may be that different groups of people with lymphoma maybe get not so good an antibody response, but an okay T cell response, and that they have no way of measuring, I don't think, or vice versa. So the answer is, I don't know, and nobody else does either.
Okay, thank you. At what point do you see a patient, stage 1 or later stages? Do dermatologists send patients to you at beginning stages? Do you see patients in unison with dermatologists?
For me, I see people before they're diagnosed. So all the way. So I'm not a dermatologist, though I have an appointment in dermatology, but I've been doing this for so long that I kind of like, I call myself a deputy dermatologist. I know this part of dermatology. So I see patients frequently when somebody's just worried about them having mycosis fungoides or some T cell lymphoma, and they want me to tell them if they do, all the way to advanced patients. Do I work with a dermatologist? I do. I need their help for a lot of things. But this question always comes up, and my answer is, you go to somebody that understands this condition and has experience. And it doesn't matter if they're an oncologist or if they're a dermatologist, because just like I know a lot of dermatology, my dermatology colleagues that do this know more oncology than most dermatologists too. So it starts to blur after a while. Yeah, we look at it a little differently. I have my perspective and they have theirs, but I think as a patient, the most important thing is just to go to somebody that's knowledgeable or have access to somebody that is.
Okay. Let's see. Do you have to suspend interferon in order to start using vorinostat or Poteligeo? Am I saying that right?
It's it's the marketed name for mogamulizumab.
Gotcha.
Tell me again, do you have to suspend interferon
In order to start using vorinostat or Poteligeo?
Well, they've never been studied in combination. I personally, I don't think they're good combinations. I'll tell you why. In the case of vorinostat and interferon, you have very similar side effects. I would imagine it would make somebody feel pretty horrible. Because interferon does the same thing, kind of weakness, achiness, a little nausea. Combining mogamulizumab and interferon would be a problem because both of those drugs have an increased incidence of autoimmunity or autoimmune conditions. So while we do combine certain therapies, sometimes without even studying them, you do want to think it through if the combination sounds like it would be safe or tolerable. And those combinations don't sound good to me. I would probably stop one therapy before going to the next.
Okay. Let's see. I was asking this person to clarify. I'm 59 years old, stage 3B, Sezary syndrome /MF, taking targretin and photopheresis every 2 weeks. Blood test not concerning. Sezary syndrome, but my skin is still patchy, and I also use triamcinolone. So I don't know if maybe they just wanted a recommendation. If you've typed that question, maybe if you could just clarify if there was a specific question, we would appreciate. We'll come back to that one. Sorry about that.
Okay.
How did we get this disease? Was it a virus, chemicals?
Don't know. So the only thing we know about lymphomas in general is that there's certain people that get more lymphomas than other people. And the kind of the bottom line has to do with immune system. So people that have a hampered immune system for some reason, either they're born with it or somebody does it on purpose because they have an organ transplant, or their immune system doesn't work like it should. They have rheumatoid arthritis, they have lupus. All of those people have an increased incidence of lymphomas. There are some drugs that predispose people to lymphomas as well that have to do with altering immunity. There's some compounds in the environment, like Agent Orange, that have been found to, it's a contaminant in Agent Orange, but Agent Orange exposure during the Vietnam War that increased people's risk of lymphoma. So there's risk factors that people might have that kind of may enhance their development of lymphoma, but the vast majority of people have none of those, and we don't know why they haven't.
Mm-hmm. Okay, the question everyone would like to know, I'm sure.
Yeah.
Let's see. I have been diagnosed with mycosis fungoides. I am told to do light therapy, but I find it difficult to tolerate. Why is this so?
Can the person say why it's hard to tolerate? They burn or they
Yeah,
get tired or?
this one, if you would be able to clarify, we can try to come back to it. We are almost out of time here, so let's see. Let's try one more question. Okay, this one's pretty general. I'm interested in the information on immune therapy in Sezary syndrome. I don't know if you had any specific questions. Let's see. Maybe we could try a different one. Let's see. Sorry, Lauren. I have 2 spots on my inner thigh, MF. My question is twofold. I am somewhat embarrassed. Don't be embarrassed, anybody. This is what these forums are for. My scrotum and underside of my penis is also somewhat red and often has a burning sensation. Could this be part of the disease? And often other areas of my skin have a burning sensation, but no redness. Thank you.
Yeah, actually, you can get mycosis fungoides lesions on your genitals.
Yeah.
So they get treated usually with, either steroids that aren't very potent because the skin there is kind of thin, or other kinds of topical therapies. So you shouldn't be embarrassed. You should tell your physician so you don't have to be uncomfortable.
Yeah, of course. That's why we do these programs, everybody, and we keep everything anonymous just so that you do feel comfortable to ask the questions that you have. That's why we're here. And someone has clarified, and maybe this will be the last question. They clarified my reaction to light therapy is fatigue and pain.
Well, okay. Some people are very light sensitive, and the only way to get around it is to be very conservative in the amount of exposure that you get. I mean, everybody that does light knows that you start off with a really small amount and then you build it up as the skin becomes more tan. But some people have to start off with a couple seconds in the box, and that's all they can do. Some people that I have like that, I actually tell them to go out in the sun instead of going into somebody's box.
Mm-hmm.
So the fatigue, I don't have a great answer for that, but it certainly is part of light therapy. And probably all of us know if we've lied out on a beach for a while that, when you go to the car and go home, you're ready for a nap.
Yeah.
If you haven't already fallen asleep, the sun and the lights, it makes people tired, and some people more than others. So I'm not sure, other than to tell you to make sure you're very well hydrated, and maybe not get the light therapy as frequently.
Mm-hmm. Okay, maybe take a break. That was our last question, and everybody can see on the screen, we've just launched a brief poll. So if you wouldn't mind just sharing your feedback with us, we appreciate it. Dr. Pinter-Brown, thank you so much for everything tonight. As always, you're
welcome.
wonderful, and everything is so easy to understand when you explain it. So we really appreciate it.